Good afternoon, teacher. I will tell you a topic, treating hypertension in chronic obstructive pulmonary disease. First, the definition. Chronic obstructive pulmonary disease is a chronic inflammatory lung disease that causes obstructed airflow from the lungs. Symptoms include breathing difficulty, cough, mucus producing, and wheezing. It is typically caused by long-term exposure to irritating gases or particulate matter, most of them from cigarette smoke. Hypertension in patients with COPD. Patients with COPD and hypertension commonly have coexisting conditions such as obesity, heart failure, and coronary artery disease. Practitioners should assess cardiovascular risk and address concurrent diseases to ensure adequate management. The benefits of antihypertensive therapy and the risk of adverse pulmonary effects or interaction with medications used for pulmonary control are specific to the antihypertensive drug class. Treatment. Management of hypertension in most patients with COPD is similar to hypertension management in the general population, with specific exceptions. Pharmacokinetic and pharmacodynamic factors should be considered in choosing antihypertensive agents for patients with COPD, along with any coexisting condition.
Disease. Chronic means the condition is going to be there, it's been there for a long time, it's going to be there for a long time. But the good news is that COPD is treatable in addition to being long-standing. Obstructive refers to the fact that the breathing test has a certain kind of abnormality with airflow limitation. Pulmonary disease, it's a problem of the lungs inside the chest. Shortness of breath, cough, and phlegm are the major symptoms of COPD that drives patients to come see their physician. Shortness of breath is sometimes first recognized as inability to do what you normally can do. In addition, many patients have what's called exacerbations. That means some acute respiratory event which is associated with more shortness of breath, more cough, more phlegm. Those exacerbations are very important and need to be treated appropriately and rapidly. The most important and common diagnostic test for COPD is a breathing test. The name of that breathing test is spirometry, but it's pretty simple. It requires you to take a deep breath in and blow it out as hard and fast as you can. With that test, we find out that the air passages are narrow, and that's sort of the classic definition of COPD, along with symptoms. In addition, there's some other tests that people sometimes have. They may go in and have a CAT scan of their chest because they have some other respiratory complaint, and one finds emphysema on their chest x-ray. Breathing tests and x-rays are the most common ways we diagnose COPD.
Can cause, but how much do you actually know about the most common smoking-related disease? Chronic obstructive pulmonary disease, or COPD.
It's a disease of the airways that causes obstruction to airflow and causes difficulty breathing. So shortness of breath is the most common symptom, along with cough and sputum production.
Dr. Paul Scanlon, a Mayo Clinic pulmonologist, says if you know someone who smokes, you probably know someone with COPD.
It affects tens of millions of Americans, 7 to 10% of the population, depending on how you count it.
While complications from COPD can sometimes be deadly, a COPD diagnosis in and of itself is not a death sentence.
If you quit smoking, lung function improves a little bit and then stabilizes so that you can live to a ripe old age with only mild impairment. You won't get substantially worse.
Applications in medicine. Intensifying antihypertensive therapy while addressing lifestyle modifications is generally recommended for all patients, at least only blood pressure goals are achieved. When antihypertensive therapy initiated or changed in patients with COPD, baseline pulmonary function or status should be documented, and agents known to exacerbate or increase pulmonary and extrapulmonary adverse events should be avoided. Pros. One might speculate that control of hypertension in patients with COPD has important clinical implications. Cons. In addition to systemic glucocorticoids as well as over-the-counter oral and intranasal decongestants, which can cause hypertension, drug interactions may adversely affect blood pressure control and predispose patients to adverse outcomes. In patients with COPD and concomitant allergic rhinitis, the use of oral decongestants, particularly those containing pseudoepinephrine, may increase blood pressure.
Chronic obstructive pulmonary disease, pathophysiology and diagnosis. Cigarette smoking is by far the most common primary risk factor of COPD worldwide. According to global statistics, approximately 210 million people have COPD. By 2030, COPD is predicted to be the fourth leading cause of death worldwide. Epithelial cells lining the airways will respond to smoke inhalation by undergoing cellular changes due to long-term exposure. Over time, chronic irritation and inflammation of the air passages causes small airways disease and parenchymal destruction. Irritation and inflammation of the air passages causes constriction in the bronchi and bronchioles of the lung. In a healthy individual, standing at rest at the foot of a staircase while breathing normally, lung volume is well balanced in terms of IRV, inspirational reserve volume, VT, tidal volume, FRC, functional residual capacity. In the severe COPD patient, lung function is extremely imbalanced with only a tiny capacity for IRV. A patient with severe COPD has a very difficult time managing everyday tasks, such as stair climbing. The patient is asked to inhale and then forcefully exhale until the lungs are completely emptied via a tube attached to a recording device. The most important values from the spirometry readings are FEV1 and FVC. If the ratio of these values is less than 0.7, then COPD is suspected. More detailed results.
My name is Gail Weinman, and I am Deputy Director of the Division of Lung Diseases at NHLBI. People can live a long time with COPD, many decades actually, so it's important to understand that there are options to allow those with COPD to live their lives fully. Even though there's no cure for COPD, these options may slow its progression and manage symptoms. You and your healthcare provider are in the best position to decide what you need and what is the best course of action for you in particular. Some of the options that are available include medication, physical training or rehabilitation, and of course, general healthy living. Let's start with healthy living. If you still smoke, the most important step you can take towards healthy living is to quit. Studies have shown that it's never too late to quit. This is a good step for you and anyone you know, whether they have COPD or not. It's not easy to quit, and there's no magic bullet, but there are many programs available at the national and local levels to help. Usually, a multifaceted approach works best. Nicotine replacement therapy or a support group or both may be helpful.
Issue applied in Ecuador. A big problem that my country has with this type of patient is a poor diet that leads to obesity. Patients can be treated with good pharmacologic treatment, but it also depends on the lifestyle that person leads, because all they contribute to a clinical improvement.
Inflammation of the bronchial tubes in the lung. And it's said to be chronic because it causes a productive cough, which means produces mucus, for at least 3 months each year for 2 or more years. Chronic bronchitis is actually lumped under the umbrella of chronic obstructive pulmonary disease, or COPD, along with emphysema. These two are different in that chronic bronchitis is defined by clinical features, like a productive cough, whereas emphysema is defined by structural changes, specifically enlargement of the air spaces.
Conclusion. Drug therapy for hypertension should be based on approaches recommended in general guidelines for the treatment of the hypertension, with special consideration of the given patient's underlying lung function and any coexisting condition, since the pulmonary effects of antihypertensive therapy vary according to the drug class. Despite the paucity of data from randomized studies of hypertension management in patients with COPD, the limited contemporary evidence supports the use of AC inhibitors, ARBs, and the thiazidas after consideration of the risk of adverse effects and interactions with medication used for pulmonary control. Thank you.